So my name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. And by the end of this presentation, we hope you're able to pronounce hypertrophic cardiomyopathy. But we think you'll be able to get that quite well. So I'm going to take a little time to introduce the concept of HCM, HCMA, and a little bit about what we do. Housekeeping items and why we're here today. If you didn't know, it's Heart Month. My jacket might have given you some indication. And February 28th, or the fourth Wednesday of February, is HCM Awareness Day. We currently have proclamations in about 25 states recognizing HCM Awareness Day, including DC, and your DC mayor may be stopping by later. So we have a proclamation from her, so we thank her for that. We need you, our elected leaders, to understand the needs of the HCM and genetic heart disease community. And this is our start of a relationship with the Hill. It's our first briefing. We hope to come back every year and update you as to how far we're going and what we're getting accomplished. We're going to be focusing on 3 imperatives: screening, treatment, and research, with the goal of more effective and timely access to care for all. We're going to be hearing from some expert healthcare providers, patients, families, and advocacy partners on the problems that set foot. What is that noise? I do not know. Oh, in session. Okay. I'm not used to that one. And how adding just a few simple questions to the Welcome to Medicare visit can help us identify not only more patients, but help to get to precise diagnosis. This session is recorded. It is public, so we're not having anybody sign any disclosures. However, we found out that the PR team from the Wizards will be here, and if you're going to be interviewed by them, they may ask you to sign a release, because we have somebody, that they think a lot of here. Okay. So what is hypertrophic cardiomyopathy and what are genetic heart diseases? There are as many as 10 million people in the United States with genetic forms of heart disease. I'm highlighting a few here because we're the HCMA and we're thinking about the thick heart diseases. But not all thick hearts are hypertrophic cardiomyopathy. They can be other diseases, and we've spent an awful lot of time and money in this country trying to figure out the human genome. And we're at a point in time where that genetic information can target care more specifically and actually help save money. We are also really excited that the first genetic therapy in HCM occurred last October. And that happened out in Cleveland Clinic with some of our friends on the team there. And there's more gene therapy coming down the line. So we want to make sure that the Hill is ready for what's coming to this area of medicine. Who is the HCMA? We're a 501c3 nonprofit. We were established in 1996. Where we have been doing our work for a really long time, kind of unheard because it was an uncommon disorder, so we thought. So we provide a lot of services to patients who are diagnosed. We have our HCMA Center of Excellence program. I'll show you a slide on that in a moment. HCM Academy, which is professional education. Our international efforts, I've just been to Brazil, where we're assisting an advocacy organization there in developing a healthcare plan for the country related to cardiac care. We have a patient registry. We run a webinar series and a podcast series. And we take care of each patient as they come in. We call them clients, not patients, with an intake and navigation call to help them specify their care and identify resources. I'm going to take one slide to tell you my story. I'm not going to go line by line on this, but to say I have come from a long family history of sudden death, stroke, and heart failure. My grandfather, my great aunt both died in the 50s, early 60s, one cardiac arrest, one stroke. My diagnosis came in 1980 at the ripe old age of 12, where I was told there was nothing that could be done to save my life. That was encouraging. I opted not to do my homework for a while, but then I got back to it. In 1990, 10 years after my diagnosis, my uncle had a sudden cardiac arrest in Montana and died in a parking lot. And that was about 4 weeks after I had had a stroke secondary to endocarditis, which was a side effect of my HCM. On the 5-year anniversary of my stroke, my sister had a cardiac arrest and died at the age of 36, becoming an organ donor. My first implantable device was 92. My first ICD was 97. In 2002, my daughter, nephew, and other family members were genetically diagnosed with carrying a myosin-binding protein C mutation. In 2008, I lost my dad to advanced heart failure and kidney failure. And on this day, 7 years ago, it was my first day home from the hospital after receiving a heart transplant. That ugly thing in the picture is my sectioned heart. I typically bring her around for speaking tours, but I had a lot to carry, so she didn't come on this trip. But if you're interested in seeing her, she is plastinized and she does travel. So I've been through a lot with HCM. And if I had to tell you that it was a good time to have a bad disease, you might think that's odd. But we have more targeted therapies now so that not every patient and every family has to experience what our family has. But today you're going to hear from some other families who've been through a lot as well. And we want to make sure that we keep families whole, and that's why we're here. So living and dying with HCM in America. We have 150,000 people approximately diagnosed right now. There's 1.3 million potentially at risk. And that's just one genetic heart disease. If you look at the CDC Wonder database, so if you've ever wondered why and how people die, toaster in the bathtub, whatever, it's in the Wonder database. So we looked at the data from 99 to 2007, and we've had that data for a long time now. The peak age of death was between 45 and 54. The great news is we've pushed that out a full decade with all the work that we've been doing, and people are surviving longer and longer and longer, and you're going to hear from a senior thriving with HCM today, and we have many seniors thriving with HCM, which kind of leads into our ask. But patients are struggling to get to diagnosis because the symptoms of HCM and other genetic forms of heart disease look like asthma, anxiety, innocent murmur, and they can often be assumed to be in young people because we hear about the headlines of young student athletes dying and these media moments, but that's not the masses. That's the rare. So there's a lot of people out there in this very building. We found a few of them yesterday living with HCM or other forms of genetic heart disease. This is our Center of Excellence map. I only bring it up to show you that we have made sure that wherever you live in the country, there is expert knowledge of HCM within about a 4-hour drive of most Americans, less in the Northeast. But we need to make sure that there's more care available and more understanding. So we're continuing this work. We'll be on the road a lot and heading out to hopefully Alaska, Washington State, and Southern California later this year to add some new programs. We have created a state report card. We want states to be prepared for cardiac arrest emergencies and know how to find HCM and other forms of genetic heart disease. So you can see how your individual states fare by going to our website, and you can use the interactive map. The QR code will lead you there. Our goal is to make sure that we have good coverage at the state level with the well child visits, that we look for family health histories, and make sure that we are getting all families screened in a timely manner. We also have some access issues that we're working on, which are about copay accumulators, thank you very much, step therapy laws, self-medication delivery, and non-medical switching laws. And his timing is frigging impeccable. I'll be one slide away. So our asks here today are simple. We are hoping that HCM Awareness Day will be recognized federally as the 4th Wednesday of February every year. We think that adding a couple of additional questions to the Welcome to Medicare visit will aid in identifying those with genetic heart disease and other heart disease. We want to ensure medically underserved communities have equitable access to screening and treatment. We want barrier-free access to care, and we need to fund our research adequately and get our promising new therapies fast-tracked to delivery to patients as soon as possible. So that is why we're here today, and I did it in under 8 minutes, and I'm really happy about that. But before I bring Jared up, Representative Sessions wants to introduce his constituent.
Jared's favorite congressman.
Come on up. Thank you very much.
Thank you very much. You look awesome. You too. Do you see the smile? This was a smile of an All-American who chose to work with a team with a big dream for a championship. He was, and his teammates were quite unique, not just with coaching, but their athletic prowess and ability. And it turned teams inside out. And it was as innovative as the wishbone or the forward pass in basketball. And it is something that since has not really been duplicated. While others tried, Jared Butler made it happen. Jared Butler, as a first-team All-American for Baylor University, with great confidence led the Bears and his team on the floor. And while he is an All-American and is a professional basketball player, he is no different than many others who come with things maybe they did not know about themselves, but that they discover, and they really realize it brings them not just back to earth, but it's something that they can talk about and be honest about and join others in trying to reach those goals of working together. Jared does not know this, but I'm a grandfather, and I'm a father, and I have 2 sons that have medical issues unto themselves. My Down syndrome son, who is 20, now 30, is a young man who, like his big brother, is an Eagle Scout and comes with some characteristics of challenges that you can see. And sometimes characteristics of our frailties or our challenges you can see, and other times they reside in an All-American that runs up and down the floor, swishes them from 40 feet, and makes it look easy. But those people that are All-Americans, that do make it look easy, also come back to earth and are willing to talk to not just you, but the Lord, and pray for himself and others who are just like him. Today, I have the honor and really the distinction to introduce you to one of God's favorite children, a young man who does care about others, who chose a university that is of faith. Baylor University is a faith-based institution with the Baptist Church. But in doing this, he has come forth on the Hill because he cares about other people. And just as I have become involved in things to care about other people, the discussion in this room will help us all to know that not just Congress, not just the NIH, not just private companies that care, but also individuals like you who've taken time to come and share your story and about the hopes and dreams. I have those about my children also. I also have them about Jared Butler and others who are just like him. So Jared, welcome to Capitol Hill. I must say that when I watched you on the court, your abilities that God gave you are almost unmatched with other young people, but that you being here today to give faith and confidence to others goes a long way. Now, lastly, I'm going to ask that one of my adult supervisions raise her hand, and she is in the back, and you will see her. She is a Baylor Bear.
Let's go.
And that is Karis Nelson. And Karis Nelson works in our office, and we many times have yell practice that you know very well. But I wanted to say to you that living a life that's full of life is what you're a part of. Young man, we're very proud of you. Ladies and gentlemen, please help me welcome HCM Journey, that is Jared Butler. And now look up. Look up for just a second, because even I want to let your fans know that we care about you. One of these, and then I'll leave. All right, second bear. Ladies and gentlemen, everybody's All-American. Go for it, Jared.
Really appreciate that. Oh man, that's a nice speech right there. Good evening. I'm Jared Butler, and I'm so excited, so fortunate enough to be here today, and for 2 reasons. Number one, y'all look pretty good. Not gonna lie to you, y'all look well dressed. I need to kind of step up my game. Number 2, I just have a big heart. I mean that figuratively and literally. And from this big heart, I just kind of wanted to share my story and things that are important to me in hopes that they become super important to you. At around 18, I was walking into my Division I college basketball scholarship, and when a pre-play physical routine changed the course of my life. So much so that the college that I was walking into closed the door on me and closed the door on my college basketball career and medically disqualified me. And this routine physical led to the diagnosis of my hypertrophic cardiomyopathy, I say it so well because I've said it so many times. But just like everyone else here, this diagnosis hit me like a truck. It hit me out of nowhere. I had no clue. I was a kid running every sprint, every suicide, doing all the extra work, every practice, every game. And without this routine physical, I would have gone undiagnosed and unaware of the state of my heart. And who knows, I wouldn't be here today speaking with y'all beautiful people. I wouldn't get this chance. I also wouldn't be here today without the treatment I received after my diagnosis from a doctor named Dr. Michael Ackerman, an elite cardiologist who helped me understand, grasp, and navigate my life with HCM. And so much so in such a way that with my HCM, my flavor, I was able to continue my basketball career and my dream. And to this day, I get to live out that dream of a 4-year-old working on his ball handling skills with a sock as an arm sleeve, counting down 10, 9, shooting a buzzer beater 3 from Reserve, Louisiana. Y'all don't even know where that's at. And to play in the NBA. And it was because, and without this diagnosis and without treatment from a doctor who actually understood HCM, I would not have to live out this dream. So I'll leave you with this. HCM is a lifelong heart condition, though many people with HCM don't even know they have it. HCM is often misdiagnosed and can be difficult to diagnose because the symptoms are like are symptoms of other conditions like dizziness, tiredness, shortness of breath. And HCM is also the most common genetic heart condition, so it might run in your family. My mom found out that she had the condition after I found out I had mine, so I really appreciate that from her. And again, if anyone in your family has been diagnosed, I really, really encourage you to go speak with your doctor, just like I did. And again, these facts became really important to me, and I hope they become really important to you. And one of my favorite quotes you can see up there, motto I live by, is control what you can control. And I was able to get my HCM under control, and I hope everybody gets theirs under control too. So really thank y'all. Feels so heartwarming and special to be here with people and meeting people like you that just like touch my heart, and hearing stories of people that kind of went through the same thing. It's kind of like we're all bonded in such a unique way. So I really want to say thank you, and that's it.
Short girl back. Thank you, Jared. Thank you, Representative Sessions, for that really great introduction. I'm not going to take a lot of time with intros, but it is my honor and privilege to introduce our next speaker, who is the director of the HCM Center at Leahy and good friend and board member of HCMA, is Martin Marin.
Great. Thank you. Tough act to follow. Tough act to follow. My gosh. No, really well said. Really well said. I think everybody would agree with that. Very, very, very well done. I'm going to just spend a couple minutes just kind of unpacking a little bit about hypertrophic cardiomyopathy for those that are here that may not be as initiated as others. So start first with just some real easy basics. And I think just pointing you first to HCM up at the top, hypertrophic cardiomyopathy, just as a visual. I think visuals are helpful here. You see the normal heart's essentially a pump. It's got 4 chambers, getting blood with oxygen to where it needs to be. And on the right, obviously schematically, is what we're talking about today, mostly, hypertrophic cardiomyopathy. And you can see, I think, represented pretty well here, that the classic finding here is that the muscle of the heart in HCM is thicker than it should be. Okay? And it's that increase in thickness and the abnormalities of the muscle itself that ultimately can, in some patients, produce symptoms and also abnormal rhythm problems. Okay? So that's what it looks like illustratively. And as we've heard already, what we're talking about today with HCM is the most common inherited or genetic heart disease really in the world. We're looking at a prevalence worldwide of about 1 in 250, and it is worldwide. And that really provides an estimated risk, or actually a number in the United States of about 1.3 million people walking around in the U.S. with this condition, HCM. Okay? And here's the major point here is that if the actual number that are diagnosed with the disease is much less than that, between 150 to 200,000. So we've got a huge gap here in the prevalence of the disease in the population and those that are actually clinically identified, patients that have a diagnosis, that are being followed in centers and getting treatment. And that gap is a problem. Right? Because that means that there are lots of patients who don't know they're patients with HCM out there potentially at risk with their disease. And that risk comes down to usually a couple things. Risk of abnormal rhythms, some of which can put them at risk for sudden death. HCM remains the most common cause of sudden death in young people, and also a cause in athletes, and also a major reason why patients become limited with symptoms and risk for stroke. So major complications. And so importantly, it becomes therefore very important to identify patients. And the reason why it's so important to identify patients is just to kind of unpack for just a second, again, these issues here for HCM and why this disease matters and why we're really here, in a way, is that, as I told you, there are a number of different complications that a patient with HCM can experience at some point in their lifetime. Remember, we're talking about an inherited heart disease, right? So we're talking about a disease which for most patients, they have their entire life. It's a chronic heart disease, and that disease can put them at risk for these complications. Abnormal rhythms that can be a source of sudden death, heart failure, and again, atrial fibrillation and stroke. And the point here is that we have today, in 2024, really effective therapies for each of these adverse pathways that a patient could potentially be at risk for with this disease. Devices that can save lives from sudden death. We've got drugs, including recent drugs specific for HCM that were recently approved in the last year and a half, as well as surgeries and heart transplant. And we've got drugs here, anti-blood thinners, ablations, other procedures. All of those can make an enormous difference in providing patients that are identified with HCM the opportunity to achieve normal life expectancy with also a great quality of life. Okay? And so because of that, it's imperative, and it really underscores the principle today that we have to do better at identifying patients with the disease and to identify them earlier so that they can have the opportunity to achieve these treatments and the goal of normal life and great quality of life. And one way to do that, and one of the asks today, is something pretty simple. Pretty simple. It's about incorporating questions, not a lot, just a few, on the Welcome to Medicare Visit questionnaire. These are questions that stand alone, that by answering them and having them on that kind of questionnaire would trigger the opportunity to identify a patient who may have HCM or other heart diseases, and by doing so, get them in earlier to diagnosis and potential treatment that will do what we want to do, which is alter their course in a beneficial way. And so the ask today, part of the ask today, is simply to incorporate these questions that would raise the appropriate red flags to do a better job at identifying patients in that way. Okay, good. Thank you. Yep.
You're all going to get down and dirty medical degrees in HCM at the end of these sessions. Okay, so our next speaker is going to share with you a pretty tough story. It's a story of loss from HCM. And I came to know Amy about 1.5 years ago about that, when she called and said, something's happened in my family. Amy, will you come up and tell us what happened? Just hit the key and it'll take to the next slide.
Thank you. Okay. So on February 15th, 2022, which is 2 years exactly today, my 17-year-old daughter, Jillian, and I, we walked into our family physician's office for her well child check. And while we were there, the doctor put her stethoscope onto Jill's chest, and she turned to me and she said, "When did Jill get this heart murmur?" And so that appointment led to us going to see a pediatric cardiologist in Des Moines. And from there, we had the diagnosis of hypertrophic cardiomyopathy. And those were severe and obstructed. They were still lingering in the air when we were waking up in Omaha, Nebraska to see specialists 1 week later. She went ahead and did a battering of tests, and then on Thursday, April 21st, 2022, the doctors were able to come back and give us our very last test result, which was her genetic test that she was positive for the MYBPC3 gene, which connects her to HCM. She came home from school that day. We went ahead and made an arrangement to see them on Monday and kind of get a plan of action. She came home an hour and a half later after I hung up the phone with the doctor, and I told her what they discovered, and she said, "Okay, that's about what I expected." She ran up the stairs where she had a sudden cardiac arrest. I was able to get up to the stairs within a minute or two. There was a lady who lived across the street who actually sold AEDs, so I had an AED on her within 2 minutes. But unfortunately, our efforts, the efforts of the EMS and the hospital staff were not successful, and we lost Jillian that day. So Jill was a very funny and outgoing girl. She loved music. She loved Harry Styles. He was her favorite. She loved art. She was really, really bad in algebra. And she wanted to be a designer one day. After Jill's death, it was like an explosion went off, and I started connecting dots within my family. And I talked to lots of families on members of my paternal side, and I found out that we had a lot of similar heart problems. With the help of Omaha, we were able to get all of my siblings, all of my cousins tested, and when we discovered that I had HCM, half my siblings had HCM, 25% of my cousins had HCM. And from then, many of us have ICDs and have had myectomies. We have also lost them. My brother has died in a surgery that was a valve surgery for an enlarged heart. My nephew has had 2 myectomies. My sister had a sudden cardiac arrest 5 months after my daughter died. And I just say that she died of a broken heart, since we're not ever sure exactly what it was. But my family is actually lucky because of Jillian, because she was our call to action. Because of her, my family has the power of knowledge to be able to fight against an invisible gene. But not all families are that lucky. But there is hope for them. Had there been big questions that were in place when I took all of my girls to their well child checks that we were asked each time, so that in 2010 when my nephew had his first myectomy, or in 2015 when my brother had died on the surgical table from his HCM, maybe some of the doctors could have put it together that we needed to do a little bit more investigation. Or when my 91-year-old father, who had HCM, and that's how he went down too, he had a sudden cardiac arrest, but if he had gone into his Medicare first visit and was able to tell them that he had 7 siblings who died, all of cardiac arrests, maybe that would have been a trigger to have them look at us a little bit easier. If we had gotten the treatment earlier, I'm hoping, it would have been hopeful that she could have got diagnosed earlier, which would have led to earlier treatment, and maybe would have saved Jill's life. And lastly, I am a nurse in Iowa, and I work at a family practice clinic. It would take me 5 extra seconds of my day to ask these questions to a patient, and that would help save thousands of dollars, millions of dollars, and keep thousands of family intact and whole. I wish it wasn't me standing here, and I wish it wasn't my daughter. I wish it wasn't my family, and I wish it wasn't that I know the heartbreak that people go through. I wake up every day and I live a nightmare. But it is me, and it is my family, and it's my wish and my hope, and I wouldn't be standing here, and none of you would be hearing my voice if it wasn't for the life of a girl named Jillian Blair, and she had HCM.
I'm going to pop her image back up there for a moment. And for anybody who's interested in learning a little bit more about Jillian's story, there's a page on the website for hcm.org where you can see some other fabulous pictures of this beautiful soul. So Amy, Michael, Jillian's dad, where'd you go? There he is. They're in the audience today, coming all the way from Iowa. So thank you for taking the trip and sharing. I can't help but get a little choked up every time I hear that story. It was so close to being able to save her life, and too late. So we can't have that happen. So I'm now going to ask another good friend from the Mayo Clinic, a little place out in Rochester, Minnesota, and the medical director of the HCM program. Steve Ammon's going to come up and talk to us a little bit more about other forms of genetic heart disease.
Thank you, Lisa. Thank you, Amy, for sharing that. And thank you, Jared, for your story. It's not that cold in Rochester, Minnesota. You get used to it. I've had the opportunity to work with Dr. Ackerman, who Jared mentioned earlier, for a quarter of a century now working on this. And the stories you're hearing today, they're important, because there are some people who say they have symptoms, and they're often misinterpreted as due to asthma or something else, because they're symptoms that overlap with a bunch of other diseases. But there are people like Jared and like Jillian who have no symptoms at all, or someone didn't ask them the right questions. And so, again, the ask today to include some of these questions is important, and it even goes beyond hypertrophic cardiomyopathy, because there are other heart conditions that are genetic in nature. And if we can find the first person in that family that has that, well, then you ask their parents and their siblings and their kids those same questions again, so it touches more than that one person. It touches an entire family and generations to come in that family that have better awareness about their disease. If you ask questions about, is there any family history of early deaths? And, well, yeah, my grandmother and my aunt both died in their 40s and it was never explained. Well, maybe this person's shortness of breath isn't asthma. Maybe they should talk about more questions and do some imaging for their heart. And so that's why there's a cascade effect. And on this slide are some other conditions which also cause thick heart muscles. It's not just hypertrophic cardiomyopathy, but now there are therapies that are specific to each of these. So we don't just want to know if a person has cardiomyopathy, it's important to know which cardiomyopathy, because the inheritance patterns are different, who is affected, what age they're affected, and again, specifically, some of the therapies are different. In hypertrophic cardiomyopathy in April of 2022, the first drug targeted specifically at the cellular abnormalities in hypertrophic cardiomyopathy was launched. This is a great new tool for us for those patients who have symptoms. For some patients, that doesn't work, and we have very specific operations that can be a one and done for that patient, and they don't have to take lifelong medication for those that are treated successfully. For cardiac amyloidosis, which is on the screen, an abnormal protein that's in the heart, there's now very specific therapies that can stabilize and reverse the heart failure conditions they have. So it's important that we ask these questions at well-child examinations, at insurance physical examinations, when you're getting your D1 entrance exam, when you're going to be an athlete. Because if we ask these questions, put a stethoscope on someone's chest, and we can hear these things, then we can make a difference in an entire family. So this is a chart that shows, again, these kind of 4 diseases. Danon disease is much more common in younger people. Fabry's has some neurologic conditions that go along with it. Amyloidosis is more common in an older population than a younger population. And so we start to do detective work and put these things together, but there are very specific therapies on the top line, and then some more general therapies that are also used in these conditions. But it's important for us to do that work together. And if we're asking our Medicare entrants and our children and our athletes these questions as they get to those key forks in the road, then we can make a difference. And it doesn't necessarily alter someone's life. They can still have a professional career in the right circumstances. They can have different professional careers that are just as rewarding in some patients. And in some patients, they get the right therapies that allow them to be active, healthy human beings and live a normal number of years. So my ask is just remember that there's a lot of misdiagnosis out there. If we don't diagnose the diseases correctly or at all, there's some estimates that we're spending over $900 billion in unnecessary or ill-advised care. So it's important that we get these diagnoses right so we can take care of our family and our friends and our patients. So thank you very much.
Thank you, Steve. So that last slide, I just want to bring to everybody's attention, the $966 billion is not just cardiovascular, it is all genetic disorders. So we are a portion of that. And if you are a staffer and you're like, well, what's with all that money? We actually don't want to spend any of your money, we want to save it. And if you ask the right questions, we can save some of those dollars by getting targeted care. So we're hoping that you will see the light and help us find these patients. So we've heard from a young man who's playing basketball. We've heard from a family who's lost a young one. But I want to bring up our next speaker, who's Marcia Rosenberg. She comes to us from Pennsylvania. And Marcia has a beautiful story, and she is the ripe old age of 81 3/4, and last seen in her modeling career on QVC. And she's going to tell us today a little bit about her story with HCM, and we're going to try not to cry, because Marcia and I cry when we need to talk.
It's going to be hard to follow that.
You got this.
Even as a child, I knew I was different. I couldn't run like the other children, was never chosen for sports. As a senior in high school, climbing the ropes was absolutely mandatory for graduating high school. Eventually, my mother went to our family doctor, and he agreed to write a note saying I had a funny EKG, and that's why I couldn't climb the ropes. It's a good thing he did that, because the school accepted it. Could you imagine if I was still in high school at the age of 81 3/4? In my 50s, I developed serious retina issues after I was diagnosed as asthma. I was given a lot of medications that eventually severely affected my sight. I went through major retina surgery. I did lose my vision in one eye for 6 weeks, but a dedicated doctor was determined to save my eye, and of course I am incredibly grateful that he did. Finally, in 2010, my issue was finally diagnosed after testing. However, the right questions were not asked, and I underwent 2 procedures that actually did not help me at all and ruined my electrical system. I had 2 invasive procedures with that. Had testing been available, this would have not happened. Months later, I was very fortunate. I was at a social dinner, and 2 retired cardiologists were present. And one of them said, "Have you been in touch with the Hypertrophic Cardiomyopathy Association?" With all my great intellect, said, "What's that?" Well, I contacted the association, and thanks to Lisa and her team, I received a phone call saying, "You have to get to a major center immediately." And she was kind enough to say where I needed to go, and I did. After a moment of, I had a moment of denial when I heard all this, what kind of surgery it was going to be, et cetera, et cetera. But I made an appointment, and I did go. After a comprehensive testing happened, I was told a myectomy was my only option. After the surgery, one of the surgeons told me that they nicknamed me in the OR and called me Tough Cookie because they didn't know how I had managed to stay alive. They estimated I couldn't have lived perhaps more than another week, maybe 2. At the age of 65, when I had my Welcome to Medicare exam, had I had proper screening, all of this perhaps would have been avoided. The screening would have resulted in earlier and proper diagnosis and treatment, rather than delaying everything until I was very near death. Screening gives us knowledge, then appropriate action can be taken. That will allow us to win the battle over HCM. With respect and gratitude to many, I'm celebrating my surgery's 10th anniversary this week.
We are taking the emotions high, we're bringing things a little low, we're bringing it back up again, and now you know why I love her so much. Just this force of nature. And her significant other, Leon, is here in the front row taking pictures that she will edit before she lets anybody else say. Okay, Deetra. We are now going to hear from a nurse practitioner about health equity and inherited cardiac disorders. Deetra DeBose comes from the Atlantic Healthcare System in Morristown, New Jersey, and is a good friend. Yes. And a member of our Health Equity Committee.
Good afternoon. That Marsha's one tough, beautiful cookie, isn't she? So I'm happy to be here. I've been here since yesterday. I've had a ball in D.C., and this is my first time in D.C., actually. But please, everyone call me D. Everyone else does. And I'm going to talk about healthcare equity in HCM. So my first slide, and I've only been given 3 minutes, so if I talk too fast, I apologize. I'm on the clock. As we know, the U.S. is a melting pot. It's a hodgepodge of different cultures. As of 2019, the U.S. population showed that Caucasian people make up 60% of the population, followed by minorities, with 18.5% being Hispanic, 12% Black, 5 to 6% Asian, followed by 2.8% multiple races, Alaskans 0.7, and the Hawaiians 0.2. It's projected by the year 2045 that the population mix will change, with which Caucasians will be less than the majority population. It's also projected that by the year 2060, mixed races will more than double, from 2.8% to possibly almost 6%. So it's going to be a lot of changes coming in the future. And then my next slide talks about the racial and ethnic differences in hypertrophic cardiomyopathy patients. So African Americans, we all know, have a history of high blood pressure, diabetes, and as a result, left ventricular hypertrophy, which is a large left ventricle chamber. Now, more times than not, they associate these large left ventricle chambers secondary to high blood pressure, because high blood pressure can make that chamber large. However, once the blood pressure is under control, in theory, the chamber should get smaller because the pressure is lower. And in some African Americans, the chamber stays large. And as of course, some of these physicians don't understand, well, why didn't the chamber get smaller, resulting in an uncertain diagnosis. And it could very well be that these African Americans have hypertrophic cardiomyopathy and are not getting the imaging, the screening to evaluate for that. And as a result, they're not getting risk stratification for sudden cardiac death. As Dr. Marin illustrated, there's a risk of sudden cardiac death if you have HCM. It's not high, it's a small subset, so I don't want anyone to get nervous, but it can happen. And as a result, there's less likely for these patients to get defibrillators, thus increasing the risk of death for African Americans. Also, too, 3 to 5% of African Americans have TTR, cardiac amyloidosis, and they're not being evaluated for that either. To the left of the screen, we're going to also move on to racial and ethnic differences for patients with hypertrophic cardiomyopathy. There's economic and residential segregation, and as a result, these neighborhoods do not have a lot of resources. For example, food deserts. There's a bodega and liquor store almost on every corner in the hood, right? Some of us drive through, getting lost. I know I have driven through some hood-type areas, and I'm like, whoa. You can get a beer, but it's hard to find a supermarket with a variety of fresh produce. In order for these patients or people, clients, to get to a supermarket to get fresh produce, which we all know is important for a heart-healthy diet, they can't walk to get to these supermarkets. They have to take a bus. Now we have Uber and Lyft or a cab. But either way, it's cost. And you can only carry so much since you're not getting in your own car and putting it in a trunk. Also, too, there's bias in healthcare workers, unfortunately. I, too, have been a victim of that. And one of the solutions that we can do is having more African American or more minority healthcare workers. And I'm not talking in the diet office or in housekeeping. I'm talking registered nurses, physicians, nurse practitioners, and physician assistants. That would be so helpful. There's also a lack of dedicated patient education and outcomes, not only for minorities like African Americans, but also for the Hispanic population. There's not a lot of brochures that are broken down into Spanish so that they can read and understand. There's also a lack of support systems, limited neighborhood and community resources, or it's limited. Like universities have a lot of community resources, but those programs are started by seed money. And unless you water and fertilize that seed for it to grow and produce and be prosperous, the plant dies, and next thing you know, the programs end. So they're great when they're there, they just have to have sustainability. I used to work at Rutgers College of Nursing, and we used to have these programs, but they would come and go as the professors come and go. So we need to have these community programs come but stay, if that makes sense. And also, too, we need to help increase the education of minorities so that they can obtain better jobs and be able to afford varied, heart-healthy foods. Because to eat healthy is expensive. I can go to the dollar menu at McDonald's and get a full meal for $3, which is not good for you. It's good going down, though, but it's not good for you. So some of the things that we could do to offset some of these differences on a national level, healthcare organization, community, and individual, we can improve neighborhood and community resources. We can have more lower income housing, and we do have laws for that, but it needs to have more teeth because some places don't want to see low income housing. You know, we're not all bad. Also increase awareness among healthcare providers to be more culturally sensitive, as well as more minority healthcare workers, which I talked about before, more patient education, different languages so that patients can certainly understand, more community healthcare workers, and not just from the universities which come and go, perhaps at the state or national level so that these programs are here to stay and can make a difference both short-term and long-term, as well as health literacy and improve education for our patients. An educated patient is your best patient.
There we go. Thank you very much. So thank you, Dee. One of the great parts of the current age of HCMA is we have a lot of phenomenal partners. Ryan, I always say your last name wrong. Gooch. I want to say Gouch, but it's Gooch. I always say it wrong. Ryan, would you come up and talk to us a little bit more about access? Because we can do everything possible to diagnose, but getting access to novel care is really important, and we work with Patch on these issues.
Absolutely. Hi, everybody. Again, Ryan Gooch. I'm the Executive Director of the Partnership to Advance Cardiovascular Health, or PATCH for short, because our name is too long. So we are actually an umbrella organization of about 20 different patient and provider cardiovascular groups that work on issues that impact access to care for heart patients. And I will say that HCMA is one of our strongest partners, and frankly, Lisa does not need our help, but she humors us and lets us hang around a little bit, yeah. So Lisa and the team and a lot of advocates have been on the Hill this week, I know, going office to office, introducing themselves. This is your first Hill Day, which is what you should be doing. Really happy to see this and hope that you can continue to do it every year. And Lisa's asked me to kind of outline a few issues that they've been talking about this week, but that we should continue to talk about that would increase access to care and increase access to diagnosis and meet some of the unmet needs that you've heard about today. So the first one that I want to talk about just real briefly, and I'll just cover these real briefly, is the HEARTS Act. And it's the first on the list because there's actually a hearing on this yesterday. And from my understanding is that Lisa actually helped develop this legislation initially many years ago. But there is some movement on this on the Hill now. What it essentially does is provide some guidelines for schools in case there is a cardiac event at schools, and also places AEDs in schools, and creates response plans for schools. So that's fantastic, and we hope that we can partner with the legislators moving that legislation, and either this year or in the future actually get that passed. The second thing, which is HCMA's real ask this week, is adding HCM screenings to the Welcome to Medicare exam. And you've heard about the impact that that would have in terms of diagnosis and then hopefully treatment afterwards. The last four pieces of legislation or potential legislation that are on this list have to do with utilization management principally, and the ability for patients to actually access the care that their clinician has prescribed. Some of these things have been rolling around on the Hill for a while, including the Safe Step Act, which would actually create some guardrails for health plans around step therapy protocols, so that when Dr. Marin or Dr. Ohm prescribe something for a patient, they actually get it and don't have to step through a number of other medications or fail on them before they get to what the doctor has actually prescribed. The Healthcare Price Transparency Act looks to essentially establish an electronic prior authorization program for Medicare Advantage plans, which would basically speed up the ability for patients to access medications that are prescribed to
to patients. The Help Copays Act is essentially designed to make sure that any dollars that are spent for a patient's copay actually go to their deductible, and this is a workaround, something that's come along recently called copay accumulator programs, which are really complicated. Would love to talk to anybody about that afterwards. But there's a lot of state legislation that's moved on this, and I'm happy to see that it's moving at the federal level as well. And then the Lower Cost, More Transparency Act, which would require PBMs or pharmacy benefit managers to disclose information on spending and rebates, which would hopefully bring down overall costs for patients if it's implemented the right way. I will say that in the swag bags that Lisa has put together, there's information on all these pieces of legislation. Lisa is a font of knowledge on these things, and I can answer some questions too. So if you have questions on them, we're more than happy to talk to you about them. But Lisa, I have to say that we work with, as I mentioned, about 20 different heart groups, and public policy is hard. It takes a long time, as everybody knows, for anything to pass on Capitol Hill. But what gives me motivation is hearing these stories, and it's the same for these legislators up here. So I can only tell you how important it is for you to be here and to share these stories, because it puts a narrative or like the real lived experience to the public policy problems, which can be wonky, and helps people understand the real human impact that change can have. So thank you for doing this, Lisa.
Thank you. So Ryan, I didn't hate that. Little inside joke. Okay, so I do want to just take one quick second, because we got about 10 minutes for questions, and if anybody has questions, Nikki will be my roving microphone holder. If anybody has questions, just raise your hand while you're getting the courage to raise your hand, because I know you're also shy, because you work here on the Hill. I wanted to say the last time I was able to be here when we actually moved a piece of legislation was the Genetic Information Non-Discrimination Act, and that took 11 years to get from start to finish, and we're really happy to have that protection so that if somebody is diagnosed with a genetic disorder, that information cannot be used against them for the purposes of accessing health care, employment, educational opportunities. Unfortunately, it doesn't cover life insurance and long-term disability insurance. Maybe you guys can work on that sometime. But we're happy to be able to have some protections over our genetics, and we all have genetic flaws. So I hope in the past 50 some odd minutes we have explained why asking a few questions can help save healthcare dollars, and that effective screening and diagnosis could save thousands of lives and lead to billions of dollars in savings, not spending. And we're hoping that you're going to go back to your office and tell your members, we've got something that's bipartisan, movable, and everybody's going to like it. So go talk to them and let them hear our voices. This video will be available online in a few days. We'll be emailing it to all of your offices. So if they miss something and you want to follow up, you can watch it again. And I'm sure our entire faculty would be happy to answer any questions that you or your members have. And we can make a difference. Patients can't wait. There are people out there at risk. We can take action to keep families whole. And I can't believe I pulled this off on the 7-year anniversary of my heart transplant. So I have to do a whole bunch of thank yous. I'm going to thank Brandy first. Brandy's my donor. All I know is her name is Brandy. She was 32 years old and she died. And her family thought enough to give her organs to others. And 7 years ago, on Valentine's Day, I left the hospital with a new heart, and I'm putting it to good use because I did 20,000 steps yesterday on the Hill. I need to thank our board of directors, our staff. Stacy, where are you? Stacy, here, Elena, Linda, and Nikki. Thank you for all that you've done. And to Julie Russo at home, who was extraordinary at putting this together, and to Ross and to Sabrina, thank you for everything that you guys have done, and to Olivia, who's created the PowerPoints and all of that, and to our new member, Kim, who we haven't really met yet because she's only been on the staff for 3 days, and we left. To all of our volunteers, I'm going to ask every person who has HCM or a family member with HCM if you could just stand up for a quick moment and let everybody see that HCM looks like everybody else in the room. You never know who it's going to be. So don't judge a book by covers, because these covers look very different, don't they? We are the melting pot. We are all patients everywhere. Thank you very much, patients. Have a seat. And to all of our partners and our sponsors, we do have members of BMS, Cytokinetics, BioMarin, Tenaya here with us today. It's going to take a village. We are going to have to work in partnership, and we are really excited to do that. And a shout out to the Wizards who brought their PR team today for our young man over here, so we thank you for that. And I guess, questions? Oh.
I think I can go my list.
Well, we're capturing this for posterity.
Never mind. Hi, I'm Cindy. I'm with Senator Blumenthal's office. I was just wondering about, and I know this is one of those, it can hit at any age and with the testing and the screening, but if there is an average age where people who are diagnosed do get that diagnosis?
So,
It's about
microphone, please, and turn it on. Oh, it's on.
Yeah. So yeah, good question. So average age for diagnosis of HCM is early 50s, midlife. So you got half the patients, younger than that and half older than that. So that's kind of where we lie out in terms of when patients most commonly come to clinical diagnosis.
Got it. And then I know the goal is to kind of get this added to the Medicare questions. What would be, and that's obviously like a really standard time where everyone 65, you go to Medicare, you get that. But seeing as, you have half older, half younger, what would be ideally the screening process that you would like to see in a dream world with this?
So I'll start with the Healthy Cardiac Monitoring Act, which we're pushing on a state level. And that would ask in every well-child examination from 1 to 19, is there family heart health history? I'll tell you a little secret. It's not about finding only the young person with HCM. It's attaching them to their parents. We had a success story in New Jersey recently where the program that we put into place about 8 years ago now, the physicians are trained in the diseases. They know what to look for because they may not have gotten it in med school because things change. A new murmur was heard by a new physician screening a 16-year-old soccer player. And he was diagnosed, he was managed, then we did the family screening, dad's been diagnosed, and now dad's family is being evaluated. So by finding one, we find the rest of the family tree. So there's a mechanism under ACA for a well-child exam. So we have a mechanistic action on the state level, but you guys can't quite do that unless we want to. If anybody wants to break into ERISA for me and make some changes, I got a whole list of things, but that's a little hard. So we're going at the state level, and we're getting some motion there. There isn't anything legislated that I have found yet. You guys are smarter than me, so you guys can figure this out. If there's a place where we can get a 30 or 40-year-old to have a standard physical, but they don't tend to go there. And they think they're fine until they get an opportunity to have a visit, which doesn't happen until 65. So if you can figure out something in between, we're all ears. We want to hear that. Okay, thank you.
Thank you.
There was another question back here. Oh. Y'all better grab food before you leave because we go out a lot of food.
Lisa, I was just going to ask, because I know New Jersey has the Healthy Child, and what can we do to get it in other states?
So I'm glad that you asked that. On February 28th, the HCMA will be holding 6 state-level legislative briefings online that are going to raise awareness at the state house level. And if you have representatives that have friends back home that are in the state legislature, we would be happy to meet with them and educate them as well. So we'll be doing a webinar for Indiana. We're going to do an update for New Jersey. We have Delaware, Michigan, Ohio. Ohio already has a draft bill for the HCM Act, so we're really happy about that. And then we're just going to keep it rolling. We're going to get our volunteers to make those phone calls and get the ball moving and go to state houses and make that testimony. So that's the goal. Any other questions? Oh, Leon.
Questions for Jarrett. My name is Leon Butler, and I was hoping that maybe Jarrett and I were cousins.
There's a good chance.
Jarrett, I know it took a lot of courage to publicly talk about your condition. My question is, what would you say to another athlete who doesn't want to be tested or screened?
I truly do think that's a great question because it's scary. When I walked in the doctor's office, I was scared. I was super unsure about what is this going to mean for my life and even my basketball career. For me, I would say your life is more important than your basketball career or your soccer career. It's just the fact of the matter. And I think with that rationale, that got me to the place where I could say, look, like I have to assess my medical condition and where my heart is at in order to make sure I live a healthy life instead of before trying to make it to, whatever I was doing on the court. So that would be my answer. Just to help them understand that your life is way more important than your basketball career, etc.
Any other questions?
Hi, I'm Danielle, and I have a son that has HCM. He's now had 3 cardiac arrests. His first one was diagnosed when he was 15, and he did not, genetically, he was not passed down any HCM genes, but he got HCM, what's called de novo, which means it was spontaneous. And he never had any symptoms. If you had ever asked me if we would ever be in this position, I would have laughed at you because he was a perfectly healthy kid. He's, healthy now. I mean, he's not healthy, but I do want to say, and I'm really heartened that people are going to focus also on getting AEDs in the schools. My school actually had AEDs all through the school, and my son when he had his cardiac arrest, was at the school. They did not get an AED to him for 10 minutes. And so it is not just a matter of getting AEDs in the schools, but it is imperative that those staff, just like they do fire drills, they need to continue to drill on doing those AED drills because they forget. And my son was really lucky. But, I worry about other people not being so lucky.
We couldn't agree more, and one of the initiatives of the HCMA that we took on in 2011 was the creation of Drill Dr. Heart, which is a script and a play that anybody in your workplace, in your place of worship, on the sports field, in school, you can practice for a cardiac emergency. In fact, on April 20th, the HCMA staff will be working with Denville, New Jersey's opening day of baseball, and we're going to be teaching each team how to drill for a cardiac emergency. You can find this online, and you can even sometimes, when we have donated items, win AEDs if you film your Drill Dr. Heart drill and put it out there. So shout out to my nephew who helped create that program back in 2011 for a combination of USA Basketball and the Parsippany basketball team. So we agree. Drilling is important. You saw the boxes on the wall. I've also been in places where you see an empty box on the wall. There's no AED in it. Please take a moment and look for the management when you see an empty AED and remind them that there's supposed to be something in the box in case there's an emergency. So part of the HEARTS Act is to fund for drilling for cardiac emergencies. So that is all incorporated. There's a lot that we have to do, so there's only an hour that we had to talk to you today. So we kind of cut it down to what was most actionable today. So any other questions? I see hands moving, I flinch. I saw that one back there. Oh.
So thank you for being here. So I'm here. My 10-year-old son had a cardiac arrest at school. And just to make it brief, thank you for looking like us and representing us, because my son wanted to be here today. Unfortunately, with school, he couldn't be here. But it's important because he was 10. And I got diagnosed because of him. He saved my life, and he also saved his brother's life because we all got diagnosed. So when we talk, each one of you had points that completely are my life right now. My life changed overnight, but he was saved in school. They did everything right, and they saved his life. So thank you guys for having the courage to speak about this. This is very personal to me. Jared, I got to talk to you a few minutes before, and I appreciate you coming out because my son would have loved to see somebody who represents him. He was a basketball player, football player, everything. He was playing basketball and went down. So, thank you.
Well, ladies and gentlemen, I think that's a wrap today. I'm like fighting back tears. So the HCM volunteers and our industry partners, I hope you come join us. We're going to go take a photo in front of the Capitol, and that we can look at each one every year that we do them for the next how many years it takes to get all these things done, and then we can laugh at how young we were then. So thank you all so much, and big shout out to my big sister, Lori. Where did Stacy go? Lori's not only my big sister, it's Stacy's mom. So we lost her a long time ago. But days like this, it seems like it was yesterday. And I think she'd be really stoked to see how far we've come. So thank you all for being part of this part of history for the HCMA. And this is only the beginning. Thanks, everybody.